Welcome everyone to another seminar in the 2020 Monash Biomedical Imaging webinar series. I'm Associate Professor Michael Farrell and I'll be your host today. I wish to acknowledge the people of the Kulin Nations on whose land Monash University is positioned. I pay my respects to their elders, past and present. On a housekeeping matter, questions for our speakers can be submitted via the Q&A facility, and answers to your questions will be provided at the conclusion of our speakers' presentations. And it's now my honour to introduce our speakers. Associate Professor Ying Lim received her PhD in 2013 from the University of Melbourne, and she subsequently undertook postdoctoral training at Brown University and with the dominantly inherited Alzheimer's network at Washington University in St. Louis. Dr. Lim is now a primary investigator of the Healthy Brain Project and the Better Brains trial, as well as a senior scientist at the Australian Imaging, Biomarkers and Lifestyle Study. Notably, Dr. Lim co-leads the Healthy Brain Project with our second speaker, Associate Professor Matthew Pase. Dr. Pase received his PhD from Swinburne University of Technology in 2014 and did postdoctoral training at the Framingham Heart Study and the Boston University School of Medicine. In addition to his co-leadership of the Healthy Brain Project, Dr. Pase co-leads the International Sleep and Dementia Consortium, the Cognitive Working Group of the International Stroke Genetics Consortium, and he continues his links with the Framingham Group. So I'll now hand over to Yen and Matt to speak about Alzheimer's disease dementia and its causes, recent findings, challenges, and future directions.
Thank you, Michael, for the introduction. Can you all see my screen? Okay, so our talk will be in three parts today. So I'll give a brief overview of some of my research on dementia prevention and risk factors for dementia. Then Yen will give a talk as well, and then together we'll describe our current research program in our lab at Monash University. So we know that the burden of dementia is increasing, and as people are living into old age, we're seeing more people diagnosed with dementia. But what's really interesting is what we're finding now is that the incidence of dementia is actually decreasing. In other words, every person's risk of dementia appears to be declining. On the left, you've got forest plots which combine data from multiple cohort studies across the US and Europe. And what we see is that each person's risk appears to be decreasing such that there's about a 13% decrease in the risk of all-cause dementia per decade, and about a 16% decrease in the risk of Alzheimer's disease dementia per decade. And it's important not to confuse the terms incidence and prevalence. So the absolute numbers of dementia are still increasing, but it seems like everybody's risk over time is decreasing. In other words, my risk appears to be lower than that of my parents, and my parents' risk appears to be lower than that of their parents. On the right, you can see the modeled projected increase in dementia over time. And you can see in red the solid lines globally and in blue in Europe. And if you take into consideration this this downward trend in everybody's risk, you can see that there's actually a substantial difference in the global burden of dementia that's predicted. However, we can't be complacent and assume that changes in dementia are going to continue with time. We don't fully understand what's driving these changes, but they do provide some optimism that dementia risk is modifiable, and a lot of my research is concerned with trying to understand factors that could be leveraged to help try and reduce dementia risk. So a lot of my research is focused on the impact of cardiovascular disease and cardiovascular disease risk factors on dementia. This describes a metric put out by the American Heart Association, which categorizes and describes ideal cardiovascular health. So it combines together 7 metrics of cardiovascular health, and patients or participants get a score of 1 point if they hit all these targets, such as if they don't smoke, if they have good cholesterol, if they have good BMI, if they have good fasting blood glucose, if they engage in weekly physical activity, if their blood pressure is at target, and if they have a healthy diet. If they do all those things, they get a score of 7. And this metric was designed to promote cardiovascular health. But we were interested to see the relationships between these overall markers of cardiovascular health and risk of dementia. And so in about 2,500 subjects that we followed for 10 years for risk of dementia, risk of stroke, they had multiple rounds of cognitive assessment, multiple rounds of brain MRI. We wanted to understand what the association was of ideal cardiovascular health with all forms of vascular brain aging. And we found that having a 1 point higher score was associated with around a 17% reduction in the risk of stroke. And that would be no surprise. But we also found that having a 1 point higher score was associated with about a 40% decrease in the risk of vascular dementia. We also found that those with higher scores also had a lower risk of developing Alzheimer's disease dementia, although the effect size was smaller for that with vascular dementia. Higher scores also associated with less cognitive decline and less brain atrophy on MRI. So for example, having a 1 point higher score reduced the rate of atrophy to equivalent to that of someone about 3 to 4 years younger. We've also looked at the intersection between ideal cardiovascular health and genetic risk of Alzheimer's disease and dementia. So on the right, you're looking at ideal cardiovascular health categorized as either favorable, intermediate, or unfavorable. And then you've got the data stratified by whether someone carries an ApoE4 allele or not. And the ApoE4 allele is the strongest known genetic risk factor for late onset Alzheimer's disease. And you can see that even in those with higher genetic risk for Alzheimer's disease dementia, having favorable as compared to unfavorable cardiovascular health still associates with the lower risk. And you've got a similar thing on the left. This time, rather than stratifying by ApoE, we stratify by genetic polygenic risk score, which includes many different SNPs that associate with higher risk of dementia. And we see the same pattern, even in those people at high genetic risk, having a good lifestyle, a good vascular risk factor profile still associates with lower risk of dementia. And this provides, I think, some hope that even in those people at high genetic risk, there may be things that they can do to help lower their risk, or at least to sort of push out or delay the onset of dementia. And also maybe has implications for disclosure of genetic information to participants in research studies. We've also done research looking at the associations between vascular health and brain outcomes and looking at time windows in which vascular risk factors might be more important or less important. What we find is that if we take a cohort who's relatively young, say in midlife with a mean age of 42 years, if we compare the brains of those with hypertension to those without, we see that those with hypertension, their brains look about 7 years older in terms of their atrophy patterns. But if we take a cohort that's a little bit older, 20 years older at 62 years, we see that hypertension is still an important risk factor, but this time the effect size is much less. It only explains around 2 years of brain aging in terms of atrophy, suggesting that the effects of hypertension on the brain might be greater at younger ages. And this is something we've looked at quite systematically. In this study, we looked at the associations between overall vascular risk factor burden and brain volume on MRI, and brain volume was used as a proxy for overall brain health. And we stratified the relationship at each age decade. So what you're looking at here is the beta estimate and standard error, so the strength of association between overall vascular risk and brain volume. And the lower the point estimate on this graph, the stronger the association. And you can see that at all ages, having a high vascular risk factor burden associates with lower brain volume. But the next thing you see is that this association is highly age dependent and is a very strong linear trend, suggesting that vascular risk factors more strongly relate to brain outcomes at younger ages. This is a similar graph, except that this looks at differences within people. So this is data from the Framingham Heart Study, thousands of people that have been followed for up to 50 years. And this looks at people who provided a brain scan at age 85. And on the x-axis, you're looking at the age in which we assess the vascular risk factors. And you can see that the strength of association between vascular risk and brain volume increases as you look further back into someone's life at their vascular risk factors, to the point where knowing someone's vascular risk factors from 40 years ago when they were in midlife actually better predicts their brain volume in old age as compared to their vascular risks in old age, suggesting that what people do in terms of their vascular health in midlife is critically important for how the brain ages into old age. In terms of the mechanisms, we find that midlife vascular health seems to predict cerebrovascular disease on autopsy. Some of our research suggests that having high vascular risk in midlife seems to be, or not necessarily relate to Alzheimer's disease in the brain, but certainly to a higher burden of having cerebrovascular disease at autopsy. And even the midlife vascular risk factor profile better predicts cerebrovascular disease pathology at autopsy as compared to vascular risk factors in late life close to death. And it's probably because vascular risk factors, in the absence of a clinical stroke, have a very slow, insidious effect on the brain, whereby damage accumulates slowly over time. And therefore, having vascular risk factors in midlife means a longer time lived with vascular risk factors. We've also done some research to look at whether treating vascular risk factors could be important. This is observational data from multiple population-based cohorts, including Framingham, but some others as well, to look at whether treatment of high blood pressure has any effect on risk of dementia. And so this combines data from over 30,000 people across the US and Europe, and we find that in those with high blood pressure, those taking medications to lower their blood pressure have around a 12% decrease in the risk of dementia, and about a 16% decrease in the risk of Alzheimer's disease dementia. Now, the graph on the right is a forest plot that looks complicated, but essentially the message is it didn't matter what class of antihypertensive medication someone was taking. They were all kind of as effective as each other. What was more important was the level of blood pressure. In other words, targeting blood pressure levels in people with high blood pressure seemed to be beneficial for risk of dementia. So to summarize, it appears that maintaining a healthy heart from an early age might have benefits for preventing cerebrovascular disease in the brain, which has implications for preventing dementia. Certainly, we know that maintaining a healthy heart is good advice for preventing cardiovascular disease. And I think in our area of brain health, one of the key challenges is how do we get people in midlife to care about their brain enough to take steps to improve and look after their cardiovascular health. So with that, I'd like to hand over to Ying, who will present some of her research findings. Ying, do you want me to stop sharing, or do you want to work from this slide set?
Yeah, I will share if you wouldn't mind. Thank you. Thanks, Matt. Thanks, everyone, and for inviting us to present at this seminar. So a lot of my work is really in understanding the heterogeneity in preclinical Alzheimer's disease. And when I talk about preclinical Alzheimer's disease, really talking about cognitively normal older adults who have some kind of abnormal marker of tau or A-beta in their brains. And one of the first things that I like to point out is that, you know, when you're dealing with cognitively normal older adults, there is a heap of heterogeneity when it comes to cognitive outcomes. You know, even when we look at the kind of later stages of the disease, like mild cognitive impairment, there is also a ton of heterogeneity. So one of the aims was really to try and understand or seek to explain some of this heterogeneity, particularly as you can see, you know, there are a group of people who are cognitively normal, but obviously over time, they're starting to show this deterioration in cognition. You know, many of you will have seen a version of this figure. This is data from ABLE, which looks at the trajectory of episodic memory composite decline over time in those who are cognitively normal, but who have undergone A-beta PET imaging to differentiate between being amyloid negative and amyloid positive. And I think that a lot of you here today are very familiar with those concepts. So as you can see, you know, they start off similarly at baseline and show this subtle but significant kind of decline of about half a standard deviation over a 3 to 4 year period. And this is supported by, you know, several meta-analyses that have shown similar results. So we're not ABLE's not the only cohort to show it. Many other cohort studies of aging and Alzheimer's disease have also shown this effect of memory decline in those who have an abnormal biomarker, whether that's through CSF or PET for amyloid. But as you can see, the effect sizes are fairly small. So about, you know, typically we would see about 0.3 standard deviation of decline per year. Other attempts to try and understand heterogeneity in preclinical Alzheimer's disease involves looking at the effect of E4. So how does we know that there's amyloid is important, but what else is important, and how does E4, which Matt has pointed out as the strongest genetic risk factor for Alzheimer's disease, how does that interact with A beta? Not only does it increase the rate of amyloid accumulation, but it also moderates the extent to which cognition declines in those who are amyloid positive. So Beth Momino is a really good friend and has modeled some of this relationship across 3 cohorts. So this is ADNI, Harvard Aging Brain Study, and also ABLE. Showing that you see, so that these 2 green and blue lines indicate amyloid negative participants who, as you would expect, don't really show any change. In fact, they show some slight improvement. And these 2 lines here, so the yellow and red, indicate amyloid positive participants. And what you see is the amyloid positive E4 carriers, which is the red line, show this faster decline in memory. We similarly showed that in ABLE. So this is mapping across the ages, so increasing age, looking at the interaction between age, amyloid, and ApoE4, and that sort of interrelationship between, do we see this added effect? How does age kind of play into this? And what we found here was really that the presence of the E4 allele really brings forth that onset of cognitive decline in amyloid positive participants, despite the fact that they are cognitively normal. Other attempts to try and understand or explain some of the heterogeneity was led by, this work is led by Noah Fiassi at the Royal Melbourne Hospital. And this is really looking at the presence of cerebrovascular risk and how that interacts with A beta to drive memory decline. So again, what we see is for the amyloid negative people, there really isn't anything going on. But for the amyloid positive people, those who also have high cerebrovascular risk, they have poorer outcomes on both a cognitive composite and also hippocampal volume, despite not really doing anything much to cortical levels of amyloid. Other work that we've been doing also looks at other modifiable risk factors like anxiety or mood. And this was work led by Rob Piaszak at Yale University in collaboration with the investigators at ABLE, showing that, again, amyloid negative, nothing happening there. But for the amyloid positive people, what we're seeing is this additional effect of having high levels of anxiety in terms of driving this cognitive decline. This now is work that I was a part of this big analysis with the Rush cohort, so the religious order study, the Rush memory and aging study, the minority aging research study. So there are 3 community-based cohorts. We pulled data across about 1,300 autopsied participants. The mean age of death was about 89 years, and about 44% of them had a clinical diagnosis of dementia at death. So the aim of this analysis was really to try and understand the contribution of age and then various pathologies to dementia. We started off by mapping out what we have, like a theoretical understanding, our theoretical understanding of how age and these multiple pathologies might drive a dementia onset. And we put them into a big structural equation model and tried to look at sort of different pathways. And this was the result ultimately. And what was really surprising here, so we've modeled sort of the classic kind of amyloid pathway with plaques and tangles. We've modeled vascular risk, cerebrovascular risk pathways, Lewy bodies, and also TDP-43. And what we see here is that once you account for all of these different pathologies in the brain, there really is no effect of age on dementia onset, which we thought was a really important observation and finding, because you often hear this. I think there's often this misconception that dementia is just part of getting older. So the good news story here is that dementia is not necessarily part of getting older, even though age is the greatest risk factor for dementia onset. And it's really about, then we can now seek to understand how these pathologies kind of interact and seek to reduce them. So just kind of really briefly to rounded up. There's a lot of heterogeneity associated with cognitive decline and Alzheimer's onset. You know, there remains no cure or treatment at the moment. A lot of trials are looking to secondary prevention now. So that's identifying people who are cognitively normal, amyloid positive, but, you know, complete cognitively normal and seeking to remove amyloid from their brains in the hope that that will prevent sort of future deterioration of decline. So it's then in this context that, you know, between Matt's work and my work, it's really this context that, you know, the Healthy Brain Project was established. It's this recognition that E4 carriers are important. So if we want to study Alzheimer's disease, we need to study E4 carriers. Alzheimer's processes are already happening very early on in midlife. It might be clinically silent, but it's there and it's happening. And if, you know, so if we want to understand the genesis of Alzheimer's disease, then we need to start in middle-aged adults. In considering that, we also then need to understand the contribution of these modifiable, non-modifiable risk factors, because midlife is also an age where, you know, things like vascular risk and stress and all that are starting to, all those things are starting to accumulate, and it'll be really important for us to try and understand how that contributes to the overall trajectory of disease onset. Finally, because, you know, we are trying to look for very subtle associations and subtle effects, we need a lot of people, right? So in science, you know, when you try and look at something very small, you need a lot of people to be able to detect a signal, really. So, you know, so that's how we set up the Healthy Brain Project. The Healthy Brain Project is an online study, people, you know, of individuals aged 40 to 70 years old. It's completely remote, unsupervised assessment. This map here just shows the distribution of participants in the Healthy Brain Project. About a quarter of our participants reside in regional or rural Australia, all across, which is really exciting and interesting for us. We don't have sort of any, you know, besides a small cohort of participants that we bring in for in-person assessments, we don't have any face-to-face contact with these guys. So it's all completely remote. And that's kind of thrown up a lot of interesting issues, a lot of design questions about, you know, how do we design platforms for remote and unsupervised assessment? And I think that is a question that's becoming more and more relevant, especially in this sort of post-COVID type era. In terms of our assessments, the study procedure is really, you know, the consent. We have a brief, really brief kind of inclusion-exclusion criteria. It's really to try and measure the population. Then they enroll the community, really. Then they enroll online, and then they complete these online modules yearly. So we measure a whole heap of stuff on their performance. And then once they've completed about 80% of the assessment, we send out a saliva sampling kit to get a sample of their saliva, and we do some genetics on them. We have you know, these two sub-studies, which we'll kind of go into a little bit in a little bit more detail in a second. As I said, you know, we've been working around this idea of adapting cognitive tests for remote assessments. You know, it's not enough to think that we can just chuck a whole bunch of surveys online and off we go. A lot of the times, you know, so, you know, you need to kind of think through the design aspect of it, right? Because, you know, you don't have, it's quite different from a clinical assessment when they come into the clinic, because, you know, you're not there physically with them. So you need to then design systems that sort of mimic you being there with them. So this is a paper that we recently published looking at really, you know, the kind of usability and the acceptability of these online systems. So we've worked with Cogstate to try and to design and validate kind of their remote assessment tool, and you'll see that, you know, this is an example of the training procedure that is required. So you tell them that you have to have these instructions that sort of pop up and tell participants what to do, and then if they make a mistake, it corrects them and gets them to a point where, you know, we are confident that they understand the test instructions. And so through this sort of design, we found that, you know, there's pretty high acceptability, high usability, and so then we can begin to now start to look at kind of more interesting disease type questions. Matt, do you want to do this?
Sure. So as Ying mentioned, we have a number of studies where we bring people into the lab to do further assessments. One of those is our biomarker study. So we invite participants to come to Royal Melbourne Hospital, where we do a number of biomarker assessments, which I'll detail in a second, to characterize the very earliest changes in Alzheimer's disease pathogenesis. We also have a sleep study where we invite people who have all the biomarker assessments to complete 2 weeks of retigraphy monitoring to look at their sleep-wake patterns. And then we also do an overnight polysomnography to look at sleep. We have a strong interest in understanding the contributions of sleep to dementia, given there's a sort of a lot of research suggesting sleep might be involved in a number of mechanisms which may increase risk of dementia. We also have a high-frequency cognitive testing study where we're looking at whether more frequent cognitive testing that's very short, but it occurs through mobile phones in rapid succession, and I'll detail that in a second. And then there's a Better Brains trial, which Ying will detail as well. Thanks, Ying. So this is an overview of the biomarker and sleep studies. So participants come into Royal Melbourne Hospital. We do in-person neuropsychological assessments, and this complements what they are already doing through that remote assessment that Ying detailed. We do a lumbar puncture to look at cerebrospinal fluid for markers of Alzheimer's disease and general markers of neurodegeneration, such as amyloid, tau, neurofilament light. We take blood so that we can look at whether markers in blood can be useful for detecting Alzheimer's disease, as well as looking at other processes like inflammation and other things. We do a brain MRI to look at brain structure, as well as QSM. And we do a hyperspectral retinal scan to look at the retina and amyloid in the retina. We're doing this in collaboration with Peter van Wintergarten. And we're trying to see whether there might be a signature of amyloid in the retina that could be used to detect amyloid in the brain. We also do a bunch of questionnaires to look at mood and lifestyle. We also take a stool sample to look at the microbiome. And as I mentioned, we have a number of assessments of sleep as well. So really detailed assessments on these people. We have funding to do quite a few participants. We've been testing for about a year, but then we had to also be on hold for about a year due to COVID as well. So we're hoping to start back up, hopefully relatively soon, and start getting those numbers up. Participants will come back every second year for these assessments. Thanks, Ying.
So Matt mentioned that, we've been looking into high frequency cognitive testing. One of the advantages, I think, of being a tech-based primarily study is that we can explore some of these more novel methods of assessing cognition. This is in collaboration with a really good friend of mine called Jason Hassenstab at Washington University in St. Louis. And it's really a test that he developed around burst design. And burst design just means that we test people more frequently within a day. So these are tests that will take about less than 60 seconds, so less than a minute to complete, but we administer it 4 times a day, and we do it over 7 days. And the hypothesis here is that this would be this kind of burst design would be a better indication of a person's true cognitive ability than a one-time only assessment at any sort of point in time. And so this is just some pilot data that Jason shared, showing the relationship between the ARC test, so the smartphone app, and their relation with CSF total tau. It performs a little bit better. It's also more reliable than in-clinic cognitive assessments, which is really promising. I've also been doing a bit of work around looking at novel cognitive tests. So in this, we describe ORCA, which stands for Online Repeated Cognitive Assessment. And the argument here really is that, we're starting to see these practice effects happen in these longitudinal cohort studies. And a practice effect is really an unintended consequence of a test that wasn't designed to be administered repeatedly. Right. So instead, what we've done here is built an actual learning test instead. So what we do is pair the Chinese character with an English word, and that's paired, over time, over a number of 6 days, and over the 6, and then they're also paired with incorrect characters. But the ratio of the correct characters to incorrect characters over the 6 days means that by the 6th day, you would have seen the correct pairing 20 more times than the incorrect pairings. And so it's an implicit learning paradigm, which is what we use when we learn and pick up new languages. So it's quite naturalistic, but it's also it's also designed to have some kind of socially relevant benefit. So when participants are doing this test, what they get out of it as well, you know, in addition to, you know, us testing their memory, is that they also get this advantage of learning, you know, learning a whole bunch of Chinese characters as well. So what we saw over 6 days was this huge effect. We tested this in older able participants who had already undergone amyloid imaging. So as you can see, the amyloid positive group shows this markedly reduced learning curve or learning effect over 6 days, which is quite exciting. And the effect size for this was greater than 2 standard deviations, which is quite incredible. When we also sought to then examine learning performance with Alzheimer's biomarkers, and what we saw was that as expected, high amyloid levels was associated with slower rates of learning. For brain volume, we observed this interaction where larger ventricles and smaller hippocampal volume were associated with slower rates of learning, but only in the amyloid positive group, right? So there's no relationship between brain volume and learning in the amyloid negative group. And I think the results of this study then provides support to our hypothesis then that cognitive dysfunction in early Alzheimer's disease is related to a failure to benefit from experience. And now we hope to sort of challenge this in other samples, including the Healthy Brain Project. And then Better Brains is really, it's an NHMRC sort of funded trial. It's a person-centered, multi-domain, 24-month prevention RCT. We're looking to delay cognitive decline in middle-aged adults. So we're hoping to randomize about 1,500 participants. Primary outcome is obviously change in cognitive function, and the mechanism here really is looking at providing a personalized behavioral modification recommendation to try and reduce these lifestyle risks of dementia.
Yen and I both work very closely with overseas cohorts, and we're very interested in sort of leveraging data that already exists. One initiative that we're leading, which has been funded by the NIH, is this Sleep and Dementia Consortium. And what we're looking at is how different aspects of sleep using gold standard polysomnography assessments relate to risk of dementia, relate to brain aging. And we'll also be looking at how changes in sleep over time relate to risk of dementia as well. So we have around 3,000 participants with these overnight sleep studies that have been followed up over, I think, about up to 18 years for risk of dementia. And this involves 5 population-based cohorts around the US. And we'll be pulling this data together over the next few years to answer these research questions. Thanks, Jen.
Yep, so that's it. These are our funders who we all thank, and our collaborators, and of course all of our participants. Thanks for coming on board and hearing our talk today. This is really sort of a brief kind of overview of what we do with the Healthy Brain Project, what we do in our lab, and yeah, ask us any questions.
Okay, well, I'll just reiterate that invitation. So if anyone would like to pose any questions, perhaps I can kick off with a question. At the outset, Matt, you were saying that vascular risk factors do seem to modify the risk for Alzheimer's disease. And a little bit later, though, you noted that that the autopsy findings weren't necessarily showing you more, classic Alzheimer's disease related things. And then Yen showed us her structural modeling. And I guess the overarching sort of impression was that there are various pathways at getting to that final point. And so I guess I'm inviting you both to speculate about how it is that vascular issues and Alzheimer's disease might interact, or are they basically just taking their own alternative paths, and this relates to our difficulty in perhaps accurately making a distinction between the two etiological factors?
Yeah, that's a really, really good question. And it's quite complex, and we're still learning a lot all the time, but it seems like they could be independent processes a lot of the time. And dementia is a clinical diagnosis, and often the more hits you have to the brain, the more likely you are to meet that threshold of having some level of cognitive impairment, which is significant enough to impact your ability to go back to normal life. And we've seen from data from the Rush cohort that Yen talked about, that the norm when people are diagnosed with dementia, the norm is that they have Alzheimer's disease and something else, or vascular disease and something else. And so I think the more sort of pathologies that one has, the greater their risk. There is some evidence to say that having high vascular risk factors can sort of maybe advance the spread of tau through the brain and things like that, but we're still learning a lot and don't have that much evidence for that sort of pathway and how it will work at this stage.
Mm.
I had a question,
here we go.
Michael.
We'll hand over to Gary for his question.
Thanks, guys. They're really fascinating talks. My question actually is a more practical one, and it's around the Healthy Brain Project. I was looking online at the website and also in the FAQs, and I'm just wondering, is it actually able to be sensitive enough now on an individual participant basis that you could identify someone who has these early signs of cognitive decline or memory loss in such a way that you might then consider it like an incidental finding? You'd have to, advise the participant, report that back to them, and they'd go off and get clinical help.
Great question, and I think it's a question that a lot of us are asking. Particularly, I know the ADNET investigators are super interested in this question, right? Because if we can use a cognitive tool to screen participants, would that kind of significantly accelerate the process? The problem is that we're entering a really new space and there are multiple layers of newness about this. First is remote assessments. We don't actually really know reliably, how they work. I think we and the Brain Health Registry and kind of cohorts like this are starting to understand that now, but we certainly don't have a good enough grasp to make any kind of clinical recommendations. The second part of that is that typically when people score poorly on a cognitive test or a neuropsychological measure, those are using really well-established neuropsychological measures that have been around for decades and decades and decades. Now, trying to do this in a remote way and in an unsupervised way using new cognitive tools, I think from an experimental point of view, it's super interesting. It's exciting that we can get these hits on cognitive function, detect these early, but I would be really hesitant about making any broad kind of clinical judgments on them, and that's the same with our participants ask us for access to their cognitive tests and all that sort of stuff, but it's like, well, we can give them to you, but we probably wouldn't be able to interpret what they mean, certainly not on an individual level just yet.
Yeah, and I think as we collect more prospective data, we can characterize changes within individuals that might be certainly not the answer, but that's maybe a more powerful way also of working out whether something is clinically meaningful.
Actually, we have another question from our audience around measurement issues. Wondering if you are seeing more variability in cognitive performance when you're using your remote assessments as opposed to the supervised assessments.
Yeah, we definitely are seeing more variability. Yeah,
And
not just from a performance point of view, but also from a behavioral point of view. So, we have participants who vary to the extent in which they can understand test instructions, and also sometimes participants want to train themselves on the test to try and kind of game it in some way. So we've had to work to put some barriers in place to prevent that from happening.
Yes. And finally, I think this will be our last question, a logistics question around how your experience of persuading people to return for longitudinal measures, how compliant are they by and large?
Yeah, so we haven't looked at longitudinal measures just yet. We are, collecting all of that sort of data. We haven't kind of sat down and properly analyzed it as yet. But yeah, it is an online study, and so participants, there will be varying levels of engagement, even at baseline. So you have some people who just sign up and the buy-in is low, right? So people sign up and then they might not do everything. what we're trying to understand now is, the characteristics of people who are willing to engage in these online platforms. What do they look like? Do they typically have a family history of dementia? Do they, what are their behavioral characteristics? And then what are the types of people who then return for longitudinal assessments? Because as much as we think that this is a platform that can be used to reach a broad number of the population, we also need to be careful that we don't end up self-selecting people who are weirdly committed to this kind of testing.
Yeah, and we're also trying to understand factors that promote engagement. So, what can we give back to people, for example, in return for their participation, so that they do come back next year?
Well, look, it just remains for me to thank you both very much for an excellent presentation, and to wish you all the very best with your future endeavours in this really important work. So thank you very much, Matt and Ying.
Thank you.
Thank you.
Thanks for the invitation. Pleasure.